Hi, and welcome to episode 229 of the Untethered podcast. Today we have Karyn Johnson-Fernandez joining us and Dr. Hope Reyes as well. Karyn is the owner of Food is Fun, Let's Eat. She's been a pediatric occupational therapist since 2010, working with many families over the years. She's realized two things. One, eating and family mealtime are a huge part of our daily lives, which creates connection to those around us. And two, as a mom of a picky eater, her love for exploring, enjoying, and sharing a balance of tasty and nutritious food and mealtimes continues to grow. These two areas combined led her to specialize in feeding therapy in order to help families feel more comfortable, connected, and successful with mealtime in their home and the community. She's taken a lot of courses to further educate herself in learning about sensory and oral motor difficulties, tethered oral tissues, breast and bottle feeding in infants as a certified breastfeeding specialist, food progression, and overall pediatric feeding difficulties. She also enjoys, values, and finds it helpful to collaborate with other like-minded healthcare professionals to ensure she's working with all disciplines of a child's team in order to provide the best quality care. In her spare time, she enjoys spending time with her family, trying new foods, cooking, and traveling to new places to make adventurous memories. Dr. Hope Reyes is a licensed doctor of physical therapy and founder of Moving Munchkins. She's a pediatric physical therapist and certified breastfeeding specialist as well. She services patients birth to 12 years of age. Dr. Hope completed her undergraduate studies at the University of Arizona with a major in physiology and minor in chemistry. She then went to obtain her doctorate in physical therapy at the University of St. Augustine for Health Sciences in San Diego, California, graduating with high honors. It's her extensive background in dance and love for everything Disney that gives her the ability to make movement fun for all her patients and families that she services. Dr. Hope is most passionate about educating parents so they feel confident to promote their child's physical strength and independence in movement. This passion to start her own practice, Moving Munchkins, Dr. Hope provides physical therapy services with developmental delay, torticollis, plagiocephaly, complex medical diagnoses, and feeding difficulties. She believes that infant feeding is a whole body function and collaborative care is essential for safe and effective feeding. When Dr. Hope is not working, she enjoys staying active and spending time with her husband, Aaron, fur child Lily, and daughter Brielle. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Karyn and Hope, I am so excited to have you guys here on the podcast today. Welcome.
Thank you.
Thanks for having us. We're definitely excited to chat with you and together and share what we've been doing.
Yeah, well, I feel like I've had a little bit of insight into what you guys do because you were so gracious and recorded, some therapy for us to share with our Feed the Peds alumni. And I mean, I can speak to what I saw. Basically, you guys work so beautifully together as an OT and a PT in a very specialized space. So I would love if we can jump into that and you can share with us a little bit about how this beautiful relationship and co-treatment model came together.
Yeah. So I'll kind of start. So I've been a pediatric physical therapist for 10 years, worked in various clinics in San Diego. And Karyn and I worked at the same clinic. And so we met back in 2015. And there was a lot of really great collaboration at that place. And so there was a lot of co-treats. And so between me and a few of the feeding therapists, including Karyn there, we started doing a lot of co-treats. And I got really interested in how postural control can help with feeding and obviously fine motor and all that, the other things that, the OTs were working on, but specifically we had a really strong feeding team there. These were more medically complex kids and at the time and, toddlers and older. So they weren't infants yet. But then as the years were going on, I kept asking my infants coming in with torticollis, they all had feeding issues, all of them. And then on the intake form, I would see tongue tie release. And I'm like, what is happening with my torticollis babies? Why are they all, breastfeeding didn't work out, or, we struggled a lot with breastfeeding. And all these things. And so I started asking the feeding therapist, can you guys start feeding infants? Like, can you help these infants? Because why are they all struggling? And so that's where it all began, I think, for us to really realize, like, oh, like the PT part of it and then the oral motor part of it have to go together. And so then we kind of started sharing infants then, and then COVID hit, and then I left the clinic. And then I opened my own practice, and then I'll let Karyn take over because then she opened her own practice. And then we kind of like got back together and started collaborating more, but it's like more specifically on like 0 to 3 age and population, and a little bit more on like the wellness side, if you will, like not always medically complex kiddos. So yeah, you want to talk about that?
Yeah, so we've known each other for years. And I do love Hope. She's so fun to work with.
Sometimes I call Karyn my mom. She like always feeds me. She's like
the feeding therapist, snack lady. I do love to eat, which is why I think I found my passion with feeding therapy, because I want everyone to eat and be happy and enjoy and be able to be with their family at meal times or, social situations. But so we did start back in the clinic years ago, co-treating. And that's kind of where I started to zero in on wanting to just work with mainly the feeding population. So I saw, the infants all the way up through middle school, and quickly learned that I like the little ones better. Yeah. So like Hope said, she left when COVID hit. I stayed on a year longer. And then I decided, I think I just can't give as much of myself as I want to in the clinic. My hands were kind of tied. My sessions were, an hour long, but I always felt rushed to tell the parents about homework and home program at the end. And I felt like there was something missing. And at that point, I had my swallow certificate, and I felt like I was at a point in my career where I was comfortable enough to say, okay, I think I can do this on my own. There are therapists out there that I can touch base with if I have questions, but I feel like I've had enough guidance and support here at the clinic that I'm ready to leave and do this on my own. So with that being said, I was nervous as all heck. And I thought to myself, well, I'm going to send some blind emails out to pediatricians, local pediatric dentists, and just say, my name is Karyn. This is what I do. I'm a pediatric occupational therapist. I'd love to meet up with you, blah, blah, blah. And some wrote back, some did not. And so to this day now, I'm still collaborating with a handful of them, which is great. And yes, once I did go out on my own and did start collaborating with those local providers, I was like, okay, I need Hope back in the picture. In my hour session of feeding takes, depending on the age of the child, doesn't matter, infant all the way to 3, it's a lot. The intake, on an eval, if the baby's not ready to feed right away, then we do something else first. Or if it's a toddler and they're running from me, it just takes a while to build rapport. So I feel like I was able to give more of myself and, have Hope come into the picture and do the Bodywork piece, as she mentioned, because it is all tied together, and feeding is a whole body activity.
That's kind of our motto is feeding is a whole body activity. And that's why the Bodywork piece plus the oral motor piece like works so well together.
Yeah. So that's how we came up with our collaborative sessions here. We do a lot of co-evals, co-treats, overlapping treats, which is also super helpful for families to minimize appointments and, length of sessions back to back.
You get that newly postpartum mom and it's like they're running around town to the release provider, and then they're seeing IBCLC, lactation, and then they're seeing us, and it's like having them come to one place. We also have a fabulous IBCLC here who's also a nurse practitioner, so she is like awesome, and the family can go from her room and just walk right over to our door and get all their questions answered and get some good homework and things like that. So it's really kind of a one-stop shop here at Lovestrong, which is awesome that we found like our people. We always talk about how like we didn't feel like we fit in until we kind of entered the space. And I feel like I hear that a lot from, different providers that treat tethered oral tissues and are in the airway space. I always felt like I treated different. I was doing manual skills on a 5-year-old, and some of my pediatric, colleagues, PTs were like, what are you doing? Like, why? I'm like, but my hands, like they tell me what's happening, it's not always just watching the movement patterns. So anyway, once I kind of got into this space, I'm like, oh, these people get me.
So important. I mean, I feel like that's, we talk so much about how like, this is not taught in graduate school programs or doctorate programs. This is not something that is like spoon fed to us. We are literally doing hours of, investing time, energy, money into learning this specialty. And then as you work, with all the patients over the years, you start to kind of go like, oh, okay, like this makes sense. Why didn't anybody teach me this? But then it's like on the flip side, finding the providers, like you said, who get it, who don't look at you like you have 5 heads, who actually will like listen to the patients and go like, I don't know how to help you, but go see these people. It's just having those referral sources. And then also like you guys have this amazing setup with someone down, right down, I don't know if it's a hallway or what it is, a couple doors down from you that also supports the patients and comes from that same educational background and understanding of the full body involvement. I mean, it's so hard to find even still today, but it's so critical. And that's one of the reasons why like we've stayed a home-based service because of exactly what you said. Like we want to make the weekly appointments since we're in ongoing therapy. Like for you guys, everything's in one place. So it's so much easier for the families. For us, we were like, well, we'll just travel to them and go to their homes, which has worked for us. And, I think when we really put the family at the forefront, I think that also it changes the entire experience with the care that you give. And I think families are, their nervous systems are a little bit more at ease. Well, they're not so at ease when they walk in the door, right? It's like, there's little things that we can do to make it easier for them to then, I think, have higher levels of success with the work that you're doing. So I love that. Again, you guys got like OT and PT, and you've covered the feeding realm. You've got the breastfeeding side of things. I think, Karyn, you're also a CBS, right? You have the breastfeeding credentials too.
We both are.
Both do. Okay. You both do. Yeah. So, I mean, it's really nice that you guys also have that understanding, but still collaborate with an IBCLC too.
We never tend to treat the whole dyad situation. That goes real deep, real quick.
Yeah. Right.
We need an IBCLC to like support that, because we could give little tips and tricks, but it's really just to understand where the IBCLC is coming from too. So just that little bit of knowledge was pretty helpful,
and have families know that we do have some training and background in that, but that we also do, collaborate with IBCLC. We are fortunate enough here at Love Strong Wellness to have that IBCLC amongst other pre and postpartum providers, chiropractor, acupuncture, biofeedback, pelvic health. So it is wonderful that we can, collaborate here. Hope and I also do home visits as well. Yeah. So if that is something that the family is needing, and it's within a certain radius, then we do honor that. And we do offer, individual and co-evals in the home if it's within a certain distance, just to, again, minimize. And some parents are a little bit more fragile, especially in the infant phase, and need more support. And so we're
pretty flexible.
Yeah, we're pretty flexible. And I wish I had this support when I was pregnant 11 years ago.
Yeah,
me too.
Every time you talk about your daughters, I'm like, me too. Yeah. I didn't know that my daughter, I was told that she has a tongue tie and a lip tie when she was born. She's 4 now. But then I was told, she's just going to fall and bust it. I was told by lactation, every baby has a favorite side. And I'm looking at my baby who was born like this, with so tight on her right side. I'm like, I know why she has a favorite side, but what's happening here? I don't know this. So anyway, now here we are in expansion and planning for a release next year, hopefully with Little Star Breathe with Dr. Hannenbosch. So we're going to get there one day.
It's a journey. And it's like, I always say it's like a blessing and a curse all at the same time. So it's like, when you know what you know, like, you know, too much, you're just like,
Yes.
oh my gosh, like I can't unsee it on my own kid. And also now I can't
Yes.
not do anything about it.
Oh,
You know?
I'm pretty sure that my daughter's myofunctional therapist is so annoyed with getting pictures and videos of her sleeping with her mouth open. I'm like, help. She's like, we're working on it. I'm like, but look at this tongue posture when she's sleeping. You know, I've even texted, you know, Dr. Hunbosh. I'm like, that release can't come like, please, like, when can we do this? You know, I'm like so anxious to do it because I just see her with her mouth open. And I'm like, ah.
And what we do now, and it's so hard to therapy your own child. So both of us and all our kids, I have 2 girls and Hope has her daughter, but we have all, you know, outsourced other therapists.
Oh, yeah.
It's very hard to therapize your own child. So we're on the journey with our kids too.
Yeah.
It's been great.
And it definitely gives you another perspective, you know, like when I connect with families, I'm like, oh, at 34 years old, I got my tongue tie released, and their jaws are like, what? This isn't just for babies, you know? I'm like, oh yeah. I was like, but it's a journey. Like, you know, there's a lot of therapy involved. And so they're always like shocked to hear that. So it's always kind of like fun fact, you know,
where the light bulb goes on. You're treating, you know, a 3-week-old infant, and you're listing off some of the things that could present later on in life. And the mom or dad in the session will just,
their eyes just,
they're like, that's me. Do I have a tongue
they're
tie?
like, what's mine? You know, and they're showing me their tongue. I'm like, I can't die. I don't know.
We always say, oh, it's a rabbit hole. It's a rabbit hole you're gonna go down, but it's a good one.
Yeah.
Yeah.
It happens so often. And those, especially in evals, or like, you know, the parents staying there kind of like you said, the light bulbs are going off and they're always like, wait, look under my tongue. I'm like, that's okay, but it's not that easy. Like, but yes, probably based on what you're telling me, but also you need an eval. So yes, there's that. Yeah.
Go see this person.
Will you tell us a little bit about like your initial evaluation process so that others can understand like how you work together and, you know, what that might look like?
Yeah. So, you know, when we book an initial co-evaluation is what we call it with both of us here, it's usually about an hour and a half. So it's kind of a long time, but you know, it's worth it for the parents because otherwise it would be 2 separate hours. And as a PT, I love it if the baby's awake for some portion of the evaluation, and it's just not possible. Like 2 hours is like a whole sleep, feeding, wake cycle in an infant. So it is nice to combine it and have it be, you know, just the hour and a half. But basically we kind of go off of what the baby's schedule is. So mom comes in and we tell them like, oh, you can hold baby, you know, let us know when they're ready to feed. So we always tell them ahead of time, we need to see a feeding, if at all possible, whether it's breast, bottle, or solids, during our time together. So if we can finagle that time-wise, or, you know, so sometimes we'll start with like the Bodywork piece. Sometimes we start right away with feeding. And so when we were talking the other day, it's just so nice to have, you know, 2 brains watching the feed. We both see very different things when the feed is happening. So we're watching, you know, breastfeeding, bottle feeding. And I'm like, oh, did you see, you know, the posture here? Did you see the shoulder retraction? Or did you see, you know, and she's like, oh yeah, and that tongue, you know? So it's like, we're both taking in quite a bit when we're observing. So it's a lot of observation. And then we're both watching what's the, you know, oral rest posture when they're in tummy time, what's happening, you know, with that tongue when they're bringing a toy to their mouth. Can they bring a toy to their mouth? So we're looking at gross motor, fine motor still because of the OTPT perspective, but really like how it all incorporates with the oral function. So again, a lot of observation, and then eventually we definitely get our hands in there. And I would say most of the time you can get in there with an infant, get in their mouth because they're little. And if they're regulated, we can do it. But there are times where we've done co-evaluations where the baby's really dysregulated, and it's just, sometimes we're both trained in craniosacral fascial therapy, which I know you interviewed Kim and Hallie recently. So sometimes we just work on the baby when they're like laying on mom, and that's all we can really do. But just observing is enough for us to go off of. Like, we don't always need our hands in the mouth. We don't always need our hands on the baby's pelvis to initiate something to help the family. So I think that's the nice part, is we're flexible. And I think the families are like, oh, because I think bringing a baby to a physical therapist or feeding specialist feels a little bit like there's something really wrong, and they get really, families can get a little bit anxious. So we try to like squish that anxiety as much as we can initially and say, we're on your baby's timeline. And this is what we're going to do. We can either do this. So we have the parents choose. Do you think they're ready to feed, or do you think they're ready to, hang out on the mat table and, we can watch their movement. And so having the parents choose is really helpful for them, because they feel like, oh, like this isn't going to be something that is like, incriminating.
We're doing this
baby
together. We're a team. Yeah. I feel like having that hour and a half time really gives us time to let the mom, usually new mom, because we see mostly infants, come in, settle, set her bags down, get comfortable. We
go to the bathroom without holding their baby.
Yeah, we offer them to go to the bathroom. We have tea and coffee in the waiting room. And sometimes their face is just like, I can do that. Like, you can watch my baby for a minute, or, they feel safe and will speak freely to the way they're feeling. Sometimes recently we had a mom who was dealing with extreme postpartum, and the whole session was a lot of being there for her.
Just being like a good listening ear.
Yeah, being a listener. And I think when they come to us, yes, like Hope said, they're anxious, nervous. What's it going to be like? What's wrong with my baby? And when they're new parents of infants, they're sleep deprived. They are like, wow, this pediatrician told me this, and this chiropractor told me this, and now now someone said I should go to the dentist. So we are a huge listening ear. Mm-hmm. And I think that giving time and just being flexible with the co-evaluation is huge. Back in the clinic days, I felt like I had to bam, 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 mm-hmm. bang it all out, or I'm not going to get this in, and I'm not going to get all the information I need to write up this eval. If we don't get all the information we need in our eval these days, not a big deal. We'll get it the next time. We will get it at some point. We don't have a checklist out when we do our eval. It's very free flowing. Mm-hmm. We might ask the parents, okay, we got your intake form. Tell me a little bit more about this. It says coughing. Tell me a little bit more about the snoring. Does that happen during the day? Does it happen during the night? Is the mouth open? Is the mouth closed? So it kind of gives us, a little bit of a template to ask more questions, but it's not like we're checking boxes and going off of something that we need to fill out to turn in. We read the parents and read the baby or the toddler or whatever, and kind of just ask questions depending on what we're seeing at the time too. Yeah. Sometimes parents don't report everything in the intake form. And when they come in to see us, we're mm-hmm. like, we should really ask about this. Or,
and they're like, oh, I didn't think to tell you that, or I didn't think that was important.
Right. So,
One other thing I was going to say too, with them coming in and telling us kind of like their story, is like, sometimes there's a lot of venting that goes on.
Yes.
And a lot of confusion. And I think sometimes, even if they've already had the release done, or if they're thinking about it and they're not sure, and they're doing some like therapy before release, it's just like, hearing like for like the third time, the same thing of what a provider has already said. Because at this point, sometimes they've had lactation say, yes, you need a release. They've had the dentist say, yes, you need a release. And then there's that third party. So sometimes that really solidifies it for them. And I do think that we're a big part, because we do have an hour and a half versus sometimes like a chiropractic appointment is like 15 minutes. It's not wrong or right. It's just, they just don't have the capacity to sit with them. So I do think our session is a big like fear squisher. And that's kind of our hope when parents come in, and we do get that perspective, we'll get the response of, oh, this was so helpful. Like the parent literally like audibly,
yes.
Oh, that was so helpful. Like they sigh at the end. I'm like, oh, that's what we want to hear. But another question that we like to ask is like, what does a 24-hour like day look like for you guys? Like, because you get some parents that are doers. And I will say, I think a lot of our parents that are doers happen to be SLPs. I don't know.
That doesn't surprise me.
So sometimes we're like, okay, this mom is the SLP. So like, we should probably like tone down the home program because she'll do it a lot.
Yeah.
Like she's gonna have her hands in that baby's mouth all day if we like, don't tell her not to. And so that's just kind of a funny thing, but we like to give homework also based off of reading the parent and reading the family of like, this mom probably can't handle more than the oral stretches from the release. So we're just really going to tone it down. Or this mom is a doer and she wants all the information. So we're going to give it to her, but we're going to tell her, let's reel it in a little. Let's not have your hands in your baby's mouth all day.
I love that. I love that. I think like you said so many good things, and there's, you know, like one of the things you said earlier too, just around parents and working with this population of, you know, having an infant kind of being in that, especially when they're still in that, you know, fourth trimester, is that parent guilt, because so many of the parents will say to us, like, did I do something wrong? Like moms, especially, like, did I do something wrong? Did I do this to my baby? Is it something that I did wrong in pregnancy? And it's, and, you know, I'm always like, you didn't do anything wrong. You did the best that you could do with the information you had. There is no way that you were changing this in your you know, like, no, like, yes, your body created this child, but also you're sitting here looking to get your child help. You're doing all the right things. And I think that, you know, speaking, I love how you really spoke to some parents just really need that ear during the eval, and the eval might look very different. There have been times where we barely touch the baby. We barely get on, and not because the baby's not ready, but it's because the parent really needs that ear of a provider who is understanding, who is going to listen, who's not going to gaslight or dismiss or tell you, oh, it's fine. It'll, you know, like your baby will fall on their face and
they're gaining weight.
They're
right. They're okay. They can stick their tongue out. I mean, we could list like 75 different things that people say.
I've told all those things with my daughter. So
right. Me too. I mean, me too. It's like, we didn't even get the diagnosis. So, and then once we had it, trying to find someone who actually would do something and work with me was like another whole story. But, you know, I think it's so critical to understand that we have to look at the patient in front of us. And I did this training. It was more myo-based, but I did a training called Airway First back in December. And it was just like a 2-hour training. And it was, a lot of it was like, half of it was surrounding my experience as an adult going through all of this myself as a patient. But the other half of it was like, everyone's like, what's your secret sauce to working with patients? Why are your patients so responsive? How do you get them to do their homework? And, you know, how do you know what to do first, or recommend first, or who they should see first? And I said, a lot of it's been a learning experience. One as myself, as a patient, being the mom of a patient, but then also working with patients. And, you know, it's not everybody's going to go down the same trajectory. Not everyone's going to get the same referral first. Not everyone's going to get the same exercises. Not everybody needs the same thing. Like we need to know it's not just about, and it's not even just about the muscles. It's like you guys said, if that parent is not ready today to do anything more than active wound care, then that is what we're doing today. And that's probably what they're doing for the next week or until we see them at their next appointment, you know, with check-ins in between. Right. And I think that's so critical, because I also get the question from SLPs, especially in my Feed the Peds course. Like I actually just recorded an episode on this recently that I don't know if it came out already or if it's the one coming out like next, but
the less is more one.
Yes. Less is more. Less is more. I was
listening to that this week.
Okay. So that must've been, that came out this week. So, you know, I have people who are like, well, how many exercises and like how many repetitions of exercises? And I'm like, whoa, pump the brakes. I'm like, first of all, what does that child need today? Because what they need today and what the parents can handle are two very different things. And maybe what happens in the next session or happened last session or happens with this other child who presents similarly. And, you know, and that's why I love, you know, what you're speaking to is really keying into like that dyad, right? And the dynamic of caregiver and child. And, you know, whether I'm working with an adult in myo or a pediatric feeding patient, what can they handle today? Like, what are they receptive to? Like just tapping into the human sitting in front of you and kind of being like, what do you need today? Right. How can I help you today? How can we work together today to like move the needle forward? And, you know, and I know we were chatting a little bit before we recorded, and, you know, I think Karyn, you said this, that sometimes we don't make progress in a session or 2 sessions or 3 sessions. Right. And I'm going to turn that over to you and let you speak to that. But yeah, I mean, I totally base my worth as a clinician or in my early days on like making progress every single session. And then later on in my career, I kind of was like, yeah, that's not possible. And also it doesn't define me as a human or a clinician, but I'd love for you to speak to that.
Yeah. So I think that as a new grad years ago, I was always under the impression, and I'm type A personality, so I'm a planner. I like to, have a list of things and I'm going to cross it off and get through those. And then I know I did my job. So I was under the impression that when I had a client, I needed to see something in the session. I needed the parents to see something. Oh, look, he crossed the shoelace over this time, but last time he didn't. Or, he picked up the spoon this time, but now I'm to a point in my career where I will front load the parents, especially if they're anywhere in the age range from 8 to 10 months, all the way to 3.5. I will front load them and just say, I might not get my hands on your child during this eval. I might not get my hands in their mouth for the first 2-3 sessions. And that's okay. There's a lot you can do in a session without putting your hands on the child. My biggest thing is building rapport with the family, first and foremost, the family and, the team, the caregivers, whoever is bringing them to the session. But with the child, especially a toddler, if I'm going to force myself upon them just to prove that we are going to get something done and they're going to walk away with something, guess what? The next session, they're going to come back and little Johnny is not going to want to get near me.
Yeah. You just lost his trust forever.
Yeah. So I am super comfortable now saying, hey, I like to front load my parents of toddlers and say, this is a journey. We can't expect your child. There's no crystal ball that says he's going to react or she's going to react this way. Just as with an infant with tethered oral tissues, some babies progress, and in 2 weeks we see major changes.
We call them those light switch babies, where it's like a light switch turns on after the release. And we're always like surprised. We're like, whoa, what just happened? I guess you're doing what you met your goals. And then there's those that take.
Yeah. Then there's those that take 6, 8, 10 weeks. I once got an email from a mom that I was working with. I started working with her baby at probably 4 weeks old. And we had some sessions. And then at about 10 or 12 weeks, I get an follow-up email from her. Hey, I just wanted to let you know we're finally exclusively breastfeeding. But this was weeks of her putting in homework. We saw each other every other week for all these weeks. And so that baby took a lot longer and it was a lot more effort and time on the mom's part, but she was really invested in breastfeeding and whatnot. But so I like to tell parents too that yes, there's no crystal ball. I don't know if your baby's going to show progress in 2 weeks. I don't know if it's going to be 10 weeks later. And I think when they hear that, especially before pre-release or pre-doing any of this stuff, it also helps to ease, because many times there's providers that will say, oh yeah, let's just do this. It's going to fix everything. We're going to do all the ties and you'll be good to go.
No.
With no mention of the collaborative care, right?
And or any other care at all.
Yes, it hurts my soul a little bit.
Yeah.
And then we call those the cleanup cases. I know that's a little bit of a harsh term, but sometimes I'll text Karyn, I'll be like, cleanup case today, where it's months post-release and they're just now, oh wait, I didn't know I needed Bodywork. I didn't even know this was a component until I saw it on a Facebook group. And I saw your name and I thought I'd just call you and see, like, what do you do? I don't understand. And I'm like,
or the provider
been doing that before and during and all the things, the release.
Or the provider, this family, like you're mentioning, has gone back to the provider multiple times, still having difficulty post-release. And it might be 6-8 weeks later.
Yeah.
And that's when they refer, well, maybe you should try feeding therapy. Then here we are back in the state of anxiousness, nervousness. Wait, what? Now you're telling me you need another thing? And then when they come to find out that, oh, maybe we should have been doing this all along.
There's that guilt.
It's another step in their journey. The guilt sets in. And so again, we are the listening ear for many of those cases. But we're flexible and we try to be as comforting as we can and advocate and say, you're here now and we're going to move forward and we're going to get you the help that you need. And so I don't know if I answered all the questions, but
no, you did. And I think
it's, I think it's a little bit less with like the Bodywork piece. putting your hands on a baby's pelvis is, or a toddler's pelvis is not as incriminating as going in the mouth. But having said that, I will say some toddlers just swat me away the second I touch their head. They're like, nope, no, thank you. So then I'm just like, okay, mom, I'm going to do it. And we have our little baby doll back there. Her name is Frenny. I have Frenny, and I'm just going to take Frenny through some movements. And I want you to do it with your child sitting in your lap. And you tell me what you're feeling. So I kind of empower the parent. And they're like, what do you mean? I don't know I'm like, no, we're just going to go slow. We're going to do some side bending. We're going to do some rotation. Tell me, do they have a favorite side? Do they have a side that's easier? So then the first couple of sessions is just mom doing it. Then the child's familiar with me by the next 2 to 3 sessions. Then I can get my hands on the child. So it does happen for me, probably a lot less, but I think we both, kind of function in that way, which is why I feel like I can look at Karyn during an evaluation and we just like, know we're like, yep, we're not going there.
We have the Mr. Mouth.
Oh, yeah.
I always say, I can do it here. I can do it on you. I volunteer, myself to do it on the parents, and some are more open and sure. Yeah. And others are like, I don't know. So that's when Mr. Mouth comes into play.
So we have our props to help us with those kids that need more time to develop rapport, which is,
Yeah. No, and I love that, because that's also like one of the questions, and it just came up again yesterday, or as we're wrapping up one of our courses, but someone at the very end of the course was just like, okay, but what if I can't get in the mouth? Like, do you refer to somebody else? Do you do this? Do you do that? And I was like, okay, deep breath. I was like, let's take a deep breath. Okay. I was like, yes, one, you can refer to somebody else, because if they're going to go to another provider who's going to diagnose that anyways, and you're confident they're not going to try and release the kids same day or next week, and before the kid is actually ready, then by all means, like, go for it, make the referral if it's important, especially if it's important to the parent, right? Sometimes the parents just like, they want that tissue exposed. They want someone to give the diagnosis. I'm like, but don't let that pressure from the parent destroy your relationship with the child. As you guys were speaking to, like, you can so quickly, avoid losing the kids' trust. You can lose the trust very quickly. And you can also very quickly gain trust by just tapping into who's sitting in front of you and what they need and what they're ready for. And it's like, I even talk to like little babies when I'm like, okay, are you ready? Can I go now? Like, it's like, I'm asking permission with like, knowing that like, they're not going to actually talk back to me at these younger ages. But at the same time, like, if you kind of see them kind of look at you and they smile a little, or they're kind of just like, they're not crying or looking like really distressed. You're kind of like, okay, they're responsive to my voice. Everybody's calm. Let's see what they allow. And, sometimes we get in there and we do something, and then it's like, they're like, okay, that was fine, but that's not fine. Or, okay, I was okay for 10 seconds, but 15 seconds is too much, and that's the other piece to it too, where I think if we could all kind of just take 10 steps back and not worry so much about what we're getting done in this session, but worrying about connecting. It's almost like, I don't know how to describe it. I always say there's like a perfect, dance between art and science, because there is no perfect dance there. It's just a dance, right? And it's imperfect and it's messy, and and again, it looks so different one patient to the next, but it's like, when you start to work with these patients, you kind of connect with them in a way where you're like, okay, I hear you. Like, you liked that. Let's do that again. You didn't like that. Let's not do that. And sometimes that's how I pick the exercises that I send home, because it's based on like what went well in the session, because I want the parent or the caregiver to have success. I don't want to send them home. And, I've had people say, well, no, when they do really well with something, I might give that like as a homework, let's work on that muscle, or let's do that exercise. But then I'll also give them something that the kid really struggled with. And I'm like, I think that's okay if the kid is receptive to it. If the child's going into like shutdown, meltdown mode, absolutely never do that ever. Because the parent is going to go into shutdown mode.
Yes.
Going to be anxious, which the kid's going to automatically be anxious. And there's that whole like interconnection of like, everybody's nervous system is now in fight or flight when we need you in rest and digest. And it's like, okay, this is a mess and this is not going anywhere. So I think I love this conversation. And I know like we've come back to it a couple of times, but it doesn't matter how many times I tell someone, I still keep getting that same question, which is why I was like, we need an episode on this. Because if you can, it's like, just deep breath and try to connect with the human in front of you.
I used to work in academia, and I taught first year DPT students, and I would tell them, sometimes you have to take off your PT hat and put on your human hat, because like, we're all still humans. And I think too, it's easy to dismiss the baby, as weird as it sounds, as a human, but babies have preferences and they have tolerance levels. and they have nervous systems just
And
like
communicate.
toddlers, and they communicate. And so, you know, when you think about like a torticollis case and, you know, oh, we're going to stretch the neck, which by the way, I don't do any stretching of the neck. It's just, I treat torticollis a little different, but, stretching of the neck and the baby screaming, or tummy time. And it's like, you know, these parents are told, well, I have to do this many minutes, and the baby's screaming. I'm like, they're not learning. They're not releasing tension if they're screaming. Like, so we have to respect that that's what, you know, your baby has a preference and your baby's telling us, and that's their way of communicating. So we have to find another way. We have to find another position, another time in the day where they're more regulated and they're happy. So we kind of give parents the grace of like not pushing it when we have those type A moms that are like, but I have to do this 5 times. It's like, well, in a perfect world, yes, but that's not human. So like we always tell parents before any oral stretches, anything where you get in the mouth, you're going to tell the baby you're going to get in their mouth. And they kind of giggle. Like the parents are like, what, you know, like, are you serious? But I'm telling you, like you said, when the baby locks eyes with you and they're cooing at you and you're like touching their lips, you're like, here I go. Can I come in? And I literally show them, do you see how your baby just opened their mouth to invite me in? They literally do it.
Yeah,
if they're regulated, they're like, oh, and they open their mouth, and then I'm like, now you can get in there. And
I think a thing to add to that too is that now that we're both out on our own, one thing that we offer for parents is to text us, to send us videos, so that if you have questions, if we send you home with 1 or 2 pieces of homework, we do it here in the session, they do it here in the session, but maybe when they get home, it looks different, or maybe they're wondering if they're doing it right and they don't want to wait. We don't want them to wait until the next time they see us, because usually it's not weekly appointments. So it's bi-weekly usually. So we have this open communication system with our families, and I get texts almost daily, if not every other day, or videos, you know, hey, here's the sleeping tongue pose. Hey, this is what the snoring sounds like. Am I doing this exercise right? I don't know if I'm getting, you know, under the tongue right or whatever. But I think that having us so close, and we do say that we'll respond within 24 hours because we both have families and they're very understanding. And I feel like it's just another level of, we're just bringing another level of comfort, humans, we're listening ear, and they feel so validated. And really buy in, and they're compliant with what we're giving them, because we are flexible. And I will say, yes, try for a series of 3. If you get 1 out of 3 and that's all you can do, that is awesome. Life happens, you're tired, you are a new mom, and that is huge. So if there's 3 days that go by and you're like, shoot, I didn't do anything Miss Karyn told me to do, that's okay. We will move on, we will move forward. Life happens, because it does.
Well, and it's also weird for these parents to get in their baby's mouth. When have you ever gotten in anybody's mouth? Like it is definitely, foreign, a tactile skill, a coordination skill to be doing like these lip, stretches, and like, oh, do you feel that band in there? Like some people don't have great tactile sense to feel the really, really thick masseter, that's in there that you can like release, or, oh, do you feel like I was saying earlier, it's easier to one side or the other? Sometimes the parents are like panicking, like, I don't feel anything. And I'm like, that's okay. They don't work with their hands in this way. So that's why it's like, oh, if you do a series of 3, maybe by the 3rd repetition, you're feeling what we're talking about. So I think there's definitely a physical kinesthetic learning curve for some of these families.
For sure.
And I always kind of joke with them. I'm like, oh, by the end of the time that you're doing the oral stretches, most of our providers, say for 4 weeks to do them. And so, oh, by the end of the 4 weeks, you'll have mastered it, and then you'll be done.
But it's so true, because, even me as like a new clinician, right? Like I hadn't been in people's mouths. And so kind of just going back to like where I was way back when, now having a parent with an infant, obviously I was also that parent with the infant. My second one was released at 5 days. We did, Bodywork with her, and I worked in her mouth and everything. But even with her, it was like, and I was working with toddlers prior to my first one, and then kind of integrated the infants in later. But yeah, even with her, it was like, does this feel right? I mean, it's really hard, like we've said, to like therapize your own child. I can do it much better with anybody else's kid. But these parents don't know like what something feels like, or what what should it feel like? What shouldn't it feel like? And I love that you spend time with them, because we do that too, is, we want them to feel comfortable when they leave. If you just show a parent a video, give them a piece of paper, they don't get their hands on doing it, practicing it, there's very minimal chance they're going to do the homework. Because one, they're afraid they're going to hurt their child. Two, there's a lot of fear, and then that ranks up the anxiety, and then the child is not going to be as receptive, like we've talked about. It's that nervous system is so important. So I love that you guys are spending this time educating, and also making sure they feel good about, oh yeah, okay, now I feel it. Okay, now I think I know what you're talking about. Okay, now we're one step closer to like feeling successful with this, because it's the same thing. I've been also the patient. I've had when I lived in Maryland, I went to this PT who was trained in what he called, or I guess what he did was manual counter strain, like not your traditional counter strain. And so, and he was like PRI trained, and, worked with like youth expansion and all that. And he would say like, can you feel this? Can you feel that? And for me, I could feel things pulsing. I could feel things, with very gentle touch. I would feel like things like flowing in my body again. And he said to me, he was like, I'm pretty sure that like only 33% of adults can actually feel this in themselves. I think that's what he said. And I was like, and I remember that clicking, like this must've been 5 years ago, but that clicked. And I went, oh, okay. So if these parents can't even feel it on themselves, these adults, like, I wonder how many of them actually can't feel it, even like when I'm sitting there training them, their hands are in their kids' mouth. Like, are they not? And like you said, different like tactile input, for different hands. And so when you said that, I was like, yeah, that's a really, really, really good point. Because even as much as we train them, it's like parents are like, am I giving enough pressure? Do I do it harder? Is it too light? And, they don't have a good feel for like what to do. And again, that fear of like, I don't want to hurt my child. We're like, well, nobody wants to hurt your child. And we wouldn't be doing this if it was going to hurt your child, but it's okay. Like, we're going to work through this together. But I think that level of support is amazing, and it's critical, especially with infants.
Yeah. Yes. I think with that being said too, and the whole tethered oral tissue post-release, the provider that we work most closely with, Dr. Bosch at Little Star Breathe, we try to see the patients within a day or 2 or 3 days. We both work out of the office there 1 day a week now as well, doing wound care follow-up. But I think that trying to see a family within that first 1 to 2 to 3 days, for the very reason you were just speaking about, is huge, because when they're in the consult and they take the video of how to do the stretches, or they're given the handout or whatnot, it's a lot, it's an hour consult and what have you. It's a great consult. But most of the time on the first follow-up, we get parents that come in and say, I hope I was doing it okay. I don't know if I'm doing it hard enough. I feel like I can't get under the tongue. They're clamping down. So being that listening ear and that reassurance, whether it's at the dental office when we're there for follow-up days, or it's here, or it's in home, and really reiterating what is to be done and showing them, no, you're not, you're doing a great job, or yeah, we do need to apply a little bit more pressure. Really, again, validates like, oh, okay. I'm so glad and we usually hear, oh, I'm so glad that I came today, or I'm so glad I was able to see you today, because I was so worried that it was reattached, or,
that's that like the biggest fear. It's like, oh, is my baby's reattached because their jaw's not opening, or they're doing this. And, so I always say we can course correct. Like you only got this procedure done 2 days ago. So we can really make sure that we're going to make everybody feel comfortable and confident that tongue is going to heal the way we want it to. And so they're like, oh, okay. They're like, oh, thank goodness. I mean, it is a lot of appointments, because they just had the release like 2 or 3 days ago, and then they're coming in again. But
usually they're so ecstatic, to come in and be like, oh, okay, thank you for validating me. It's never an appointment where they're like, oh, we're here again. They're like, okay, I just want to make sure I'm doing everything right, and like, what else do we need to be doing? So
Yeah,
really
we
just
do that.
validating.
We do that too. And like, I think that 24 to 48 hour, like after the release happens window, if you can get to a patient and make sure
Yes.
that, the caregivers feel really confident about like what needs to happen now. I think that's huge. And, we also work with some older kiddos and, elementary and through high school and even adults with the myo side of things. And for them too, I mean, half the time they're not confident, or the kids like not loving how it feels while it's healing. If they maybe had sutures placed, and they're not wanting to eat, or they're afraid to speak. And we're just like literally sitting with them there, trying to get them, and I've done this with toddlers too, just sticking their tongue out a little bit at a time. Just like, okay, how did that feel? Okay, great. Can we go a little bit more? Okay. How did that feel? And then they'll be like, that was ouchy or something, be like, okay, that's where we stop. We don't want it to be ouchy. Like, we'll work on that more later today or tomorrow, and so I think like, I always loved those sessions because I felt like they were so, for the parent who's like so nervous to go through with the procedure, to then see this on the flip side, like even within like hours or a day or two, like, and even with the babies who are still struggling, the parents always will say something along the lines of like, oh, they don't feel as tight, or okay, now, because we've worked on this so much leading up to it, now they feel the difference. And I think that is so critical. I've always said like photos and videos are great, and I think definitely show change. So absolutely love them. However, feeling it and experiencing what it feels like before and after, especially for the caregiver. I mean, I think those light bulbs go off in their head and they're like, oh, okay, now it all makes sense. Like it's clicking. Okay. I see what's going on. And I think that's especially helpful too, especially like with our infants who are really still struggling to feed. And we're going to take, a while to really get on track post-release, even though we've done all this work leading up to it. Because it's like all those little like glimmers of hope where like the parent, something connects in the parent, and the parent's like, okay, I'm with you. I get this now. Okay, why are we still struggling? And then that's like the next conversation. It's like, okay, well, you know how we did this to get here. Now we have to do this to get there. And we don't know how long that'll take. Like you were saying, like some kids are, I think you call them the light switch, they get the release and boom, it's like everything's functioning. And you're like, whoa, how did that happen? But unfortunately that's less common than it is, than it is like the norm. So most of our kiddos definitely, we see several weeks to several months. And then if there's other more involved kiddos, like from a motor standpoint, that can be plus of, follow-up therapy, depending on what's going on. But yeah, I think I love how you guys take this approach that's very supportive, I think, and very, family forward, because I think that's how it needs to be. There's way too many.
Well, and I think too, like the providers we work with, like, specifically Dr. Hanenbosch, like, she emphasizes what we need to get done too. So it's like, if we're all saying the same thing to the family and they're getting that repetition of like, it's gonna, she never promises the light switch situation. And in fact, she probably more often says, it's going to take some time. And I think like, I can always tell, like, I don't even need to see on paper if where the family got their procedure done for their child, because if the family is more open to the therapies and they're more like, their expectations are set better, by certain providers who do that education and take that 5 minutes to say, hey, listen, this is a journey. This is, even with those infants, like the mom is in pain, breastfeeding and all that. Like I want that light switch to happen, but like, realistically, those families are so much like better supported and better, their expectations are just set. And I can always tell if they've heard this from their IBCLC or the release provider before they come to us.
Well, many of the families too, I will come to the first session and they'll say, oh yeah, Dr. Hanenbosch said her part takes care of the anatomical structure, but we need to work on function and we need to work on, and I'm like, oh, I didn't have to say it. She's already said it.
So beautiful.
Which is huge. But I will reiterate that. And I will say, I'm sure Dr. Hanenbosch said in your consultation that her part, strictly takes care of the anatomical portion of what's going on. Myself and Dr. Hope are going to look at function and how is this impacting feeding function, motor movement patterns, tension patterns. The dentist doesn't do that part, so that's why we are a team. That's why we collaborate, and when they go back for their third follow-up, which is their last follow-up 4 or 5 months post, we hear from Dr. Hanenbosch all the time is like, wow, like what a huge, like
different baby, different kid. Mom, the mom's not, coming in, holding their baby with their shoulders up. Like you could just tell the parents look different too.
Yeah.
So
Yeah.
that's the fun part, to see like that end journey, like success cases and, parents that have reached their goals and, it's just fun.
One thing I just want to add too quickly is, when I like first came into the space and went out on my own, I was so used to having kids in the clinic on my caseload for months at a time, years at a time. And so when I was in this space and on my own and working with these more typical kids, I felt like I was doing something wrong at first, because I would have maybe 3 sessions, 5 sessions, 6 sessions. And then I was like, I don't think this kid needs me anymore. Like, what is going on? Am I not seeing something? And I would
see something.
Am I missing something? I would, call Hope and be like, hey, and she would say the same thing. And I feel like the time, the energy,
the collaboration
is what really is like so huge.
Yeah.
And so it took me a few months of this repetition of like, I only saw that kid 3 times, and they're like, are they really ready to be discharged? Are we really ready to be done? For me to realize like, yeah, this whole team approach, like, I don't need a kid on my caseload for a year. I mean, maybe there's check-ins. And so some of the infants that I see, that are done working with me at 3 months, sometimes parents will call me back at 6 months when they introduce solids, and I will, revisit the family and do a session or 2 based around that. But
it's the same with torticollis too. So like in the clinic, we would have to wait for the pediatricians to refer. And they're getting a little better. APTA has spit out a little bit of research saying by 8 weeks they need to refer. I'm like, I had a 20-day-old in my office the other day, and I'm like, yes, yes, yes. And I'm like, guess what? I felt the same way. I'm like, wait, they're getting better faster because they're young and they don't have as many milestones to reverse or enhance, or, he's sitting, but he's like this, or he's rolling to one direction. I'm like, a 20-day-old doesn't have that many milestones to like fix, right? So I was like, they're getting better faster because I'm seeing them earlier, and I'm not waiting for somebody to tell the family that they need to come see me. So it's really like this conversation, like on the PT side of things, is it really torticollis, or is it just idiopathic postural asymmetry? We're fixing it before the torticollis comes in, before the neck really looks like it's the biggest issue. Because from my perspective, it's not the neck. The neck is the symptom of something else going on. And then there's the tethered oral tissues and the mouth tension and all that. But, the whole body approach is like, there's something else like pulling on that child, on their hip or their pelvis, their trunk, something else. And the neck is just, so we could stretch the neck all we want, but you're not going to fix the problem, and the tilt's not going to go away until you look at the trunk. So, but I get these babies like discharged faster. And when I was in the clinic, I wouldn't get a baby with torticollis till like 4 or 5 months. And I would always think to myself, where were you 3 months ago? There's no way that this just happened overnight. And these parents would say, oh yeah, they really did like looking, to this side, but I didn't think it was a problem because the pediatrician didn't catch it.
Let's wait and see.
Yeah, let's wait and see. Or my favorite one is just, oh yeah, just dangle a toy to the side that they don't like to look. I'm like, well, babies avoid movement that challenges any tension. So there's no way they're going to look to their non-preferred side unless they get that body work done. Like, I don't know how you're going to do it unless you just force it. But getting them earlier is like, it's almost like wellness versus reactive care. And I love being on the wellness side. And I think that's my favorite thing about like having my own practice, is that I feel like I'm like doing things before it's a problem. Obviously they have, feeding issues and all of that, but I'm doing it before it's like a really big gross motor problem. And then we don't need the cranial remolding helmet because we fix the range of motion, and now their head is growing round and it's beautiful. But yeah, they discharge a lot faster. So it is a little bit weird being on like more that wellness side, catching it earlier. Families are coming directly to me, not waiting for their pediatrician to agree. So that's like my favorite part about it. It's like so fun to see them discharge in like 5 sessions.
Right.
If you would have told me that like 10 years ago, I'd be like, no way, it takes way more for a baby with torticollis.
Yeah.
Well, I think that's the beautiful thing of like being in private practice for yourself and being able to like, call the shots and educate and hopefully get the kiddos in earlier. And, I have parents who always come and they're like, oh my gosh, is it too late? I'm like, no, it's not too late. But depending on your child's age, we have more, like you said, more to undo, more to catch up on. And certain, it takes a little bit longer, and that's a bigger investment in many ways. So, but I always tell parents, I'm like, the earlier, the better. Like early intervention is so key. And we've talked about that on the podcast a lot before, but I'm like, if we could just get every pediatrician to sit in a room together and somebody could come and talk to them, and we could have this conversation with them and be like, hey, like when you see that newborn or that baby at 1 or 2 weeks of age and mom's got these concerns, it can't hurt to send it to a provider who does what we do, because we may save them months of depression, months of feeding issues, months of motor issues. I mean, everything you just listed.
And money and time.
I mean, and I think that's, I appreciated our pediatrician that I had when my girls were young, because they had like the questionnaires for mom, and they had the questionnaires for baby, so they could flag any issues, with postpartum depression or an anxiety or anything else going on with mom, where they felt like it might be helpful to refer mom out too. And so I really appreciated that, because I feel like that's not standard. And we need to be supporting the caregiver who's taking care of this child that they're the pediatrician of. But at the same time, it's like, I feel like there's been so much more conversation around like mental health, but I'm not seeing it translate to everyday practice in our young moms or moms of young and, new infants. And anyhow, that mean like in a perfect world, if we could just, get all these people in one room, educate them, send them off on their merry way, I think we'd all be a better off.
Now go do.
Disperse. Do.
Hope and I both have made little flyers for people in the community, pediatricians, other providers that we would like to collaborate with. And it's more for that discipline, not for the parents. So it's for the pediatricians, and they can look on the back of it and it says, you put on there if your baby is 0 to 2, or if the baby is 0 to 2 months and the parents are coming in and, they have this complaint or this residual, whatever's going on, send them to me. So it's more, we're trying to educate and, those who, we're trying, those who, some are more accepting than others. But I do feel like we are slowly getting more referrals from
younger babies.
Younger babies, and providers are like, oh, I just got another referral from this pediatrician, or, oh, this family came in and said the pediatrician said that we should probably see feeding therapy before we blah, 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 blah. So, it's still rare, but we're seeing it. Slowly, but surely.
It's harder to tap into that classic medical model. It's really hard to change their process, to change their perspective and all of that.
Well, it's like the bigger
hospital,
higher ups too. So we have a lot of moms that come in and say, I had a mom 2 weeks ago that was like, the nurse in the hospital whispered to me and said, I feel tension under your baby's tongue, but I can't say anything. So when you get discharged, go for a second opinion. The nurses, their hands are tied. So it's just, we do what we can.
I mean, I had that experience as the mom where I was like, okay, I know too much. I'm not going to go in my child's mouth. Like, silly Hallie, like, okay, as soon as the baby latches to breast, like, you're not going to know if your child has a tongue tie. Like, really? I mean, the second she like latched, I was like, oh, this is like Lily all over again. Okay. All right. I don't even need to look in the mouth. I know what's going on in here. There's a lot of tension, and maybe there's a tie, maybe there's not, but there is definitely tension, and we've got to do something about it. And so like day 2, I basically showed the pediatrician when they came to visit from our pediatrician's office, and she was like, yep, you're absolutely correct. Like 100%. As soon as she diagnosed it, or the outside pediatrician who came to visit inside the hospital, then the nurse was like, oh, do you want our hospital doctor to release that for you? And I was like, don't touch my baby. Like, wait a second, there's gag orders. You can't diagnose it. But as soon as my external pediatrician did, now you want to bill my insurance. No, like, this is not, I was like, and no, you're not releasing it today because she's not ready. Like, they were like, they wanted to take her to like do hearing tests outside of the room. I was like, no, you can do that right here. I was like, nobody's taking my child after that experience.
Don't touch her tongue.
Like, this is a room in hospital. My child is not leaving my side.
Good for you. And I think reminding parents too, that you are your baby's or your child's biggest advocate, and for them to hear that from us on the outside, like, trust your mom gut, because just last week I was with this family that I just mentioned. The mom was told that in the hospital, and she's seen multiple providers since, and got the runaround. And so she also is dealing with some postpartum now, but I just really wanted her to feel validated and said, reminded her numerous times in the session to trust your gut. You are her mom, you know her the best. If you don't feel like something's right, ask for a referral for somewhere else, or, seek someone else. You really have to have that comfort and that level of understanding with a provider you're going to work with, or you're not going to get anywhere if you don't,
I just wrote a blog post the other day because I was feeling pretty spicy, and it was really meant for it was really meant for like other providers, and to understand, like, when a parent comes to you for a concern for their child, it's real. Whether or not development, or physiology tells you it's a real concern, you either need to validate their concern, then educate as to why it's typical. Oh no, your baby shouldn't be crawling at 6 months. I get that question a lot. Like, that is way too early. That's crazy. Closer to 9 months, 9, 10 months. So you either validate and then educate as to why it's not a real medical concern, or you refer to the right professional. And if you're not the right professional, like you only have two options. Like, it's not that complicated. So, but I think a lot of times, like in that classic medical model, we forget to validate, and then we don't educate, and we just say, nope, it's not a big deal. But like, they need to know the why. Why isn't this? Why shouldn't my 6-month-old be crawling? Because I had a play date with another kid, and that 7-month-old was like on their tummy, and my kid doesn't even do this. And I'm like, so like that validate, then educate, like that doesn't happen a lot of the time. And I think that's really hard for parents, because then they leave not feeling heard, even though, like, it's not a concern that your baby's not crawling at 6 months, but nobody told you why. Nobody took the time to say that comes later. It's your baby's they're sitting, they're rolling, they look great in tummy time. Like, this is what your baby should be doing. And then they're like, oh, okay. Then that concern is gone. And I feel like more often than not, I guess, select sample size because of the babies that come in our office, more often than not, the concerns are real physiological issues.
Yeah.
So like,
same, like I've like had my jaw on the floor with some of the things that parents have told me they've said to pediatricians and have been dismissed. And I'm like, hold on. I got to write this one down. I'm like, I just got to write this one down because I need to go have a conversation with somebody. Like, this is not okay. It's like the things that you hear. I mean, and just, it's sad to say it doesn't surprise me anymore, but nevertheless, it breaks my heart like more and more every single time. And then what really grinds my gears since we've gone here is, the providers, the professionals, especially like in the SLP world or in similar, therapy spaces that have entire social media accounts dedicated to quote unquote educating other providers and parents.
Yeah.
And they're like, oh no, this is not evidence-based practice. And the research doesn't support this. And this is that. And this is, I'm going, okay, there is evidence. And there, we don't have to go into this whole conversation, but it's very dangerous because one, it's unethical. Two, we're spreading misinformation, and that is dangerous. It's actually like you can be sued for that. Yeah. And, and then they put the disclaimer, like, this is not medical advice. I'm like, oh, great. So you have just now spread all this misinformation, but you're going to put your little disclaimer so someone can't sue you, and then there's a bunch of providers behind the scenes, like pulling their hair out because it's like, well, this person's account says this, right? Yeah. Hi, it's me. And then there's and then they go and speak for big national organizations and things, and we'll just end there. But
similar things happen in the peds PT world, where it's like there's this really big fight of quantity versus quality of movement. So like for that kiddo that's delayed and this and that, like, some PTs are like, get him in orthotics, get him in a gait trainer, like get him moving. And it's like, we can appreciate that weight bearing is important after one. We can appreciate that structure is a big deal with orthotics. But I'm like, but wait a minute, like quality still matters. Like I'm pretty sure the majority of the colleagues of like pediatric PTs would think I'm nuts by like what I see, what I treat. Like it's not an issue because we're all trained under AMA, not down to them. And we're all trained to react and not to be proactive. So there's this battle in the pediatric PT world of quality. Like it doesn't matter, just get the kid walking. And it's like, but it does matter. It actually really does. The quality does matter. So there's
those
like
are the
similar
kids
things
that you see from the clinic who are like, oh yeah, I started walking and they discharged
Oh.
them. And then we get them and we're like, what?
They started walking at 24 months. And I'm
Right.
like, I'm so happy they're walking. That's
That
wonderful.
goal check by, it's like,
Right.
okay, wait, hold on.
And then the parents again aren't educated on like, do you want to take a break? Your child's walking. Here's some home program. No, it's like you're walking. The parent
Right.
thinks that they'll just magically be fine, or that they're caught up to typical milestones. And then I get them at like 30 months and they can't even go up and down stairs. And I'm like, but wait, like what happened when you got discharged with walking? And they were like, oh, they said he was fine. And I'm like, they're not fine if they're walking a year late. It's not fine.
That's a whole other, that's a whole other.
That's a whole other ballgame. But so the quantity versus quality is huge. And same thing, the quantity people are the loud ones at the conferences. They're the ones that are like, this is evidence-based, because there's really only evidence to practicing the task to make sure that like the motor milestone is achieved. And I'm like,
how can
that
you
it just
on-
doesn't
To what
even
expense? Like at what expense to the child,
what
and what else are we not working on? It's like, it just completely dismisses root cause medicine. And I do love that, like, there are people in this space, like, especially with tongue-tied, infants and everything, that are working on research and publishing things and, trying to really beef this up a little bit so that we can hopefully silence some of that. But, that's where I think it also makes it so much harder for parents, because they're like, well, I'm seeing this split camp even on social media, which is where everybody hangs out all day, every day. And especially like when these moms are breastfeeding their babies and they're on Instagram, right? And they got their phone up and they're scrolling. Like, that was me. I, no shame in the game.
I'm like, what else can I learn?
Right? I know. I'm like, oh my gosh, it's 1 a.m. I got to go to bed. It's like, that's life. It's like, we're all doing it, but that's why it's so dangerous, and why there is, and then a lot of these organizations and even licensure bodies are like, oh, we don't monitor social media. I'm like, what? Like, if somebody's deliberately spreading misinformation and causing harm, that's not an issue like surrounding life. There's no licensure issue here. No. Okay, cool. And I think that they are starting to change that a little bit with like how, like, predominant of a media, massive media, Instagram, all the social media channels are now. But still, it's like, that's where I say to parents, look, like, walk in here, forget everything you think you know, and like, let's just like work with your child and see what happens, and see like what your child tells us. And like, you tell me what you're like, you guys, what you said. What are you feeling? Okay. Do you feel that? Like, how's your child responding? Like, what's going on here? Because at the end of the day, I'm like, the best provider, in my opinion, is the one that's going to listen to the family and is not going to go, oh, but this paper said, like, I'm sorry. I don't care what the paper said.
We had to do it 5 times and you have to take this. And
right. Well, and I think that's also part of like, in a lot of therapeutic models, it's like, okay, step 1, step 2, step 3, do this, like you said, it's quantity, quantity too. Like, okay, now in step 1, we do this 10 times. In step 2, we do this 15 times. In step 3, this happens. And so when we have students come in and they're like, well, what do we do first? I'm like, well, what does the patient look like? I'm like, what do you mean? What do we do first? Like, we have to eval the patient to figure out, like, let me teach you how to do an eval so we can see what we do first. And, and that might not even be what we do first. Right. And so, like, of course there's generalities where it's like, okay, we need to have jaw stability. And that's kind of a basis for a lot of everything else going on the orofacial complex. However, like, what we do first is not like a step 1, step 2, step 3. And I think that's also what makes it complex for like therapists and
especially new grads. I was shocked within pediatrics how much observation and hands-off time there is, whether it's in an eval or a regular session. You got to look at that baby's active movement before you get your hands on them. And there's so much more observation than I ever thought I would do. Like, your eyes have to be so quick to see it, because that baby's probably not going to do it again.
I've had parents go like, are you going to go? And like, I've had parents say to me like, okay, are we going to go in their mouth now? Cause it's like 40 minutes of the eval has passed. And like, we've been chatting, but like, I'm also like you said earlier, like, I see some things that they probably didn't think to report. Like, let's talk about that. Or, okay, they checked this box, or if they wrote this on the intake, I want to like dive into open-ended to let them elaborate, because I think this has got some really good, helpful information right here, and so it's very conversational based. And at the same time, while we're talking, we're doing the same thing. We're observing the baby. And I like to see in the beginning too, like, does the parent leave the baby in a carrier? Do they come in wearing them? Like, what does that look? I mean, I'm not a PT, but I feel like this is helpful information, and that positioning that they're in a lot. And parents will say, is it okay if I take the baby out? I don't like to leave them in the carrier. I'm like, yes, please do. Like, please take them out of their car seat. And I would love for you to like hold them, wear them, put them down on the floor, whatever you want to do, whatever they're happy with. But yeah, it's, thank you guys so much for sharing this, because I think it's a very fear-based approach, I think, to feel like, okay, I got to know like this hierarchy, and I got to get in the mouth, and we got to do all these things, and I have to make progress every session after that. And, it's like all these things that I think we're conditioned, maybe like through our graduate or, doctoral programs, like we're kind of conditioned to approach therapy that way. And it's like, we have to break that conditioning in ourselves in order to actually like work with these patients.
Yeah. And it starts in the academia programs, like having been in academia, they teach to the board exams.
Yeah.
So there's not much space or time to go through that, and unless they have a really good clinical instructor out in the field, really hounding that,
doing this.
it just doesn't get taught to these students, these new grads, So
I think to piggyback on that though, too, as a new grad, and kind of what you were saying, there's these people on social media that are saying, all these things. Now, as a therapist in the last, however many years, when I've felt like, okay, I got this, I can do this. I know a lot of things, taken a lot of courses, but I still have aha moments where it's nothing I learned in a course. I just trial and errored something by myself, and guess what? It worked for the
experience.
Clinical experience. That's so I wanted to say, that yes, that it's huge. Clinical experience is a huge piece of it.
Yeah. And that is part of evidence-based practice for those who are not familiar with like what it is. Evidence-based practice is more than just research. It's also the clinical experience, and it's also the patient, like that, especially in this case, the caregiver and the infant, like their goals and what they want to work on is that's also part of that whole approach. Yeah.
So I just wanted to speak to that, sometimes there's these aha moments where you're like, oh, I put this and this together, and oh my gosh, look what this kid just did. Like, I haven't done that before, and I'm learning every day. I make mistakes, and I learn from my mistakes still, always will.
That's the great thing about our professions, that we're learning every day, or like I'll learn at the same time as the parent. We kind of look at each other, what? Like one day I was doing some, body work, and I was like, this is how your baby was inside of you, and like all twisted up and like that. And she's like, well, it's funny you say that, because when he nurses, he really tries to get into this position. I'm like, that's his position of ease. It doesn't surprise me that your baby's really smart and getting into the position that makes him feel nice and homey and gooey when he tries to feed, so that everything else is relaxed and he can just work on his, mouth. And she's like, oh, and I was like, oh.
I love it. I mean, and that's, again, like I also talk about, like, we are lifelong learners. Like, none of us know everything. Like I've said since the beginning, like, I want anybody who comes through like therapy with us, or, one of my programs online, one of my courses, certifications, whatever. I'm like, I want you to know more than me when you leave. I want you to feel like you have like surpassed me. Like I'm not doing my job if I haven't elevated you, if I haven't helped like you kind of get to the next level for yourself to then continue on your journey. And like, whether that's with me or somebody else, like that's what we should all be doing. And that was like this whole elevation movement thing that I created, kind of by accident 3.5 years ago, I guess it was, where it was like, I'm just so tired. I was tired of the gatekeeping in like this space. I was tired of, I'm like, we're only hurting patients if we're not willing to help each other. And so like, what's the point? And I was also tired of going to classes and leaving and being like, okay, I have ideas of like what to do next with like 3 kids on my caseload, but I don't know what to do after that. And I don't know what to do with like the other 17 kids on my caseload. I was like, okay, what is happening? And so I just was like, all right, I'm done. Like, no more. Like, we need to have something that speaks to like what I wish I had as a new grad, so that I could, or even like later in my career, just so that like, there's a jumping off point. There's something that makes me start to think critically. Like, I was like, I feel like I'm leaving these courses and I'm just like, I don't know, like, I don't know what to do next. And it was more through like my clinical experience and talking with other colleagues who kind of helped me bounce ideas back and forth that I kind of started to go like, okay, yeah, let's try this with this kid. And like, I don't care if there's an article that supports that or not, because it's what works for this child. And that, in my opinion, is the best therapist can think critically.
Yes.
And work with the child and kind of feel what's going on. And that takes experience too. So I always tell like our new grads, I'm like, breathe. It's going to take time.
Give yourself time.
It's going to take time. And like, you're going to feel like you're probably going to feel really uncomfortable in the beginning because you're going to be like, I don't know what this feels like. But the more you get your hands on like more faces and bodies and everything, the more you'll start to understand. So like, just give yourself time, and there's no magic number. Some people after 5 babies are gonna be like, okay, I'm starting to feel it. And some people after like 25 babies are gonna be like, okay, I'm starting to feel it.
Yeah.
So, and I'm very hands-on. So like, for me, it's like a pretty quick, like I feel one versus the other. And I'm like, oh, all right. That one felt different than that one. I'm not sure what's going on yet, but they're not the same. Okay, let's figure this out. So that's where I try to like, just give everyone a little like glimmer of hope, especially like therapists that like so badly want to be in this space to, you know, be kind to yourself, be patient with yourself, and like, let yourself just work with the little ones that are in front of you and try to tap into like everything we talked
Patients are our
about.
best teachers, you know?
Yeah.
And it's okay to not have the answers. It's okay to say, I don't know.
Yeah. And you can
but
say
I
it
will
to a
find
parent, you know?
I will find someone that knows and get back to you, or I will do some research and get back to you. As a new grad, I always felt like I had to have the answers. And what if this parent asked me this question in an eval and I don't know? I'm going to look so bad. And, you know, no. You will never know everything. So if you don't know, you don't know. And a parent feels much better hearing you say that than coming up with some fluff because you feel like you have to
say something,
fill the space. But it does take time, and it does, you know, it can leave you feeling uneasy, but saying no is okay. Like,
but you're human. You're human. It's like, stay in integrity with yourself. Don't make something up if you don't know it. And like you said, the parent is going to be so much more appreciative if you're like, you know, hey, I don't know, but let me connect with a colleague and I'll get back to you. I think a parent's going to be like, oh my gosh, you're actually going to like go talk to somebody else to try and get me an answer versus like, just, you know, they may believe what you tell them, whether it's true or not, unfortunately, but you know, that's where I just go back to like, just tap into like what you're feeling in the moment, who's in front of you, like, and nobody knows everything. I don't know everything. I know you guys don't know everything. I know the educators that are like 30 plus years older than us that teach in the space don't know everything. And, you know, I think that these are things that are not like, being human is not discussed ever. So just remember, it's okay to be human. And even one of the things too, that like in the beginning, when I was working with infants, I was straightforward with my patients because I was like, they're private paying. I want them to know that like, I really used to working with toddlers, but I've recently done a lot of education in the space. I'm collaborating with a lot of colleagues. We're doing some co-treat type of things, you know, but at the same time, like I'm new to working with infants. And so I would tell parents straight up, like, I'm a feeding therapist, but my expertise really has been 12 months plus. I'm newer to working with infants and I'm here for you. And we're going to work through this together, but I just want you to know that. And, you know, and I think when you kind of lay it out on the table and you're honest, you know, even being like, I'm a new grad, but I'm here and I want to help you. I want to help you and your child do this. Like, let's work together. I think that goes so much further than being like, you know, trying to hide that you're new to this space, because they're going to sense that something is off with your energy. And I know this goes like a little too woo for some people, but like energetically, people are going to sense like the nervous systems talk, you know, to each other. They're going to sense that, just like a parent and an infant, you know, their nervous systems talk too, more than
and the
ours
kids
will.
sense that too.
Yeah. You know? Everyone senses it and nothing goes well when we're all kind of like, you know, hiding behind masks. So it's like, let's really like kind of take the mask off, like just be real, be human. And I think parents, again, are so appreciative. You know, once in a while you'll get a parent who's like, no, you know what? I want someone who has like 10 years of experience. Well, that's not the right patient for you anyways. So they're going to probably drive you like drink. So, which is fine. Let them go somewhere else, you know, but it's like, I love the humanizing part of the whole process, because that unfortunately I think is the biggest piece that's missing in today's current medical model, insurance-based medical model, I should say. So is there anything else that like we haven't discussed that you guys wanted to add?
I don't think so.
All right. Well, then tell us where they can find you.
Well, we both are somewhat active on our Instagrams, not a ton.
I'm not so much.
Yeah.
You still have good content on there.
Yeah, some content on there. So mine is Moving Munchkins on Instagram.
And mine is Food is Fun, Let's Eat on Instagram. And we both work out of Love Strong Wellness, which is a center in North County, San Diego. We also both work out of Little Star Breathe, which is a pediatric dental office with Dr. Hanenbosch in Carmel Valley, San Diego. So yeah.
Awesome. Well, we'll also make sure that we have that linked below the episode so they know how to reach you if they want, if they live out there, because I think everybody who does should probably come see you guys. But thank you so much for joining me today. This was so much fun. I know we could just talk for hours and hours.
Yeah. It was fun. Thank you so much for having us.
Yeah. I appreciate being here talking, and we'll talk again, I'm sure.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyoTots airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at HallieBalkin.com or pop over to @HallieBalkin on Instagram to get all the latest updates.